We're going to start off. Welcome again. I'm glad to see as many folks here this morning. And we're going to start off this morning with substance use disorder challenges and solutions. And this panel is going to be moderated by Tom Renfree, the Deputy Director for Substance Use Disorder Services, County Behavioral Health Directors Association. Thank you, Tom. And the panelist is Warren Daniels, Chief Executive Officer of Community Recovery Resources. And Warren's from Northern California, up in my neck of the woods. So, in fact, we have a contract with Warren on for some beds. And Wayne Seguda from Los Angeles County. So we have sort of a more rural setting to a very urban setting and for discussion this morning. So, Tom, I'm going to turn it over to you.
Thank you, Tom. Good morning, everyone. Well, we're glad you're here because we've saved some of the best for last. and I think you're going to, we've got two great presentations this morning, and these are a couple of examples of substance use disorder programs or agencies that have really been proactive and led out in integration efforts to integrate and collaborate with mental health, substance use disorder, and primary care services. We have one that's a large county agency, in fact, the largest county from Los Angeles. And then we have a program provider in a small county, and both of these programs have been successful in working toward integrated health care. So our first speaker, and I'm going to go ahead and introduce them both up front, and then they can just take it from there. Our first speaker is going to be Warren Daniels, who is the CEO for a program he has programs in Nevada County and Placer County, two small counties. The particular program that he's going to be speaking about today is in Nevada County in Grass Valley. It's called CoRR, Community Recovery Resources, a program which has been very effective because they've been successful at forging partnerships to provide integrated health care, and that's what this conference is about. It's about partnerships in providing integrated care. I have visited the campus for this program. It's incredibly impressive what they are doing in this small community to provide a whole continuum of care for substance abuse services, for mental health, and now more recently have been integrating with primary care services in that community. So Warren's going to tell you about that. It's very impressive. Daniels has served as the CEO for CoRR since 2001, and he's been with the agency for 19 years. Warren is also a licensed advanced addictions counselor and a certified criminal justice professional. He's also the current president of the newly formed California Consortium of Addiction Programs and Professionals. This is a new association that was formed as a result of the merger. It's all about mergers these days, right? This was the merger of the California Association of Addiction Recovery Resources, CAR, and CADAC, the California Association of Drug and Alcohol Counselors, and they recently merged to form CCAP, and Warren is the current president of that. Warren has also received numerous state and local awards for treatment, leadership, and innovation. And I'll stop there because if I say much more, and there is a lot more to say about Warren, but he'll get embarrassed and then he'll get mad at me later. I don't want that to happen. So Warren will be our first speaker, and then following Warren, we're going to hear from Wayne Seguda talking about the Los Angeles County Department of Health Substance Abuse Prevention and Control Division and the programs that they have, particularly around their regional approaches to addressing health disparities from a wellness approach that integrates mental health, substance use disorder, and physical health care. Sometimes they call this the Health Neighborhood Initiative. So Wayne's going to be talking about that. Wayne is the Deputy Director for the LA County SAPC. He's worked for 25 years in various positions with the department. The Department of Health Substance Abuse Prevention and Control Division is the county agency responsible for administering substance use disorder prevention, treatment, and recovery services for Medi-Cal beneficiaries and uninsured individuals through contracts. They have contracts with 150 community-based organizations, as well as the directly operated Antelope Valley Rehabilitation Centers. The department also oversees the operations of state-certified drug diversion and driving under the influence programs. And so without further ado, I think I'll turn this over to Warren, and then he will present, and then we'll have followed by Wayne. So thanks for being here, you guys.
All right. Thank you, Tom. Good morning again, everyone. How about a round of applause for each and every one of you out there that work so hard every day helping people get well. Thank you. I'm honored to be able to be here and talk with you folks today. This is not my typical venue, but when Tom asks me to do something, I usually do it. So I'm here for Tom. As Tom mentioned, we're located primarily in Nevada and Placer counties, but we are a regional organization that has focused on primarily substance abuse issues for the last 40 years. We're celebrating 40 years this year, just this year. Welcome to the campus. Let's see if this thing works. Fabulous. So this is the issue that we deal with every day. Everybody has their diagrams that work for them. This is the one that brought us to the campus concept that I'm going to talk to you about today. And we focus on substance abuse, but realize that substance abuse is a constellation of complications that embraces both substance abuse, mental health, and physical health. And without looking at all of these different areas in an individual or a family's life, we will really get nowhere. And that was one of the things we realized back around 2005 when we started developing this concept. As all of the communities in California were just riddled with methamphetamine addiction in the late 1900s and early 2000s, our grand jury took it upon themselves in Nevada County to write their annual grand jury report stating that methamphetamine was an addiction in our community. And being the only community-based organization that worked with substance abuse at that time, myself and our board of directors and some of our key staff really took that to heart and started doing some progressive thinking on what would a model look like if there were no barriers, if there were no silos. And what I'm going to tell you about is the concept that has developed from those discussions. It's taken us to places that we really never thought that we would be at. And as I was explaining to Tom earlier, it's very much like peeling an onion. Every time we peel a layer, we realize that there are more layers that need to be peeled. And integration is an action word. It's not just a stationary word. So the campus, as we developed this, we really looked at what were the deficits that we were experiencing. People didn't have access to care, very low outcomes. You couldn't get folks to work together. Coordination of care and integration were two things that just were not happening. We developed a plan that encompassed a wide variety of services from detox to aftercare. And when we put that together, we developed a letter and sent it off to California Endowment in 2006. And we didn't hear anything back from them, and about 4 months later, they sent back a check with nothing attached, but sent us a $40,000 check. And said, please create a business plan based on the letter you sent. I took that to our board of directors, and they kind of chuckled and said, well, I guess we have the funding to try and figure out how to do this thing. Let's give it a try. And we brought together some individuals that we'd worked with over the years to help us develop a financial model, help us develop a business model of what an integrated program would look like in a small community. And these statements up here are just some of the things that we came up with. Our focus of our discussions were the three aims of access, multidisciplinary approach, and physical sustainability, which were our guiding principles. And what ended up happening was, developing this campus model that had physicians working alongside of behavioral health folks and drug and alcohol counselors, and then coordinating their care on the back end as well. Here's a picture of the campus. How we got to this picture, I don't have enough time to tell you how we got to it today. But what I can tell you is it brought together partners from local, national, and levels. And we used Prop 46 dollars. Some of you may be familiar with that bond initiative to purchase the property. That is the back of a golf course. Tom always says, is that a golf course there, Warren? It is. But yeah, that's the end result of recovery there, is being able to go out on the golf course. But this property right here is really the property that we ended up purchasing. It's about 3.5 acres. And getting the funding through HCD to purchase this property, there were some older homes there, and we started out with transitional living. But in developing that business plan, we realized that to do the scope of the work that we had envisioned was going to cost us somewhere in the neighborhood of $10 to $12 million. And at that time, we were an organization of about 25 employees, and we had an annual budget of maybe $1.5 million a year. And so we were visioning some big things to be able to make this model. When we were able to purchase this property with HCD funding, that gave us an enormous amount of credibility. We sought out federal partners with USDA Rural Development Community Facilities Program, and they helped us with an initial loan to create a master plan. And once we created that master plan and presented it to them, they said, wow, well, you're ready for a full application now. Should take about 90 days, and we're pretty sure that we're going to get this funded for you. This was right around 2009, and as you folks remember, in 2009, the financial climate in California was not very welcoming to anything in real estate or new ideas at all. But after a year and a half, not 90 days as they had originally said, we were awarded $9.3 million loan to build this campus. What you see in front of you is 37,000 square feet of new program. This building right here is your outpatient program. And what you have in that outpatient program is you have a primary care clinic, you have a child development program, you have licensed behavioral health folks, you have substance abuse counselors and support staff, all working in unison in an outpatient setting. What you have across here is this could actually have been two separate buildings. If you follow that red light there, over here you have a men's residential program and detox program, and here a women's residential program and detox program of about 40 beds, and they don't receive any medical services there. We had to build the medical services across the parking lot because the regulation does not allow medical services to happen in the residential program. So as we were developing this program, we had to also deal with the regulatory nuances that keep us in a lot of the silos that we're in today. Integration, once again, is an action word. This over here is a 20-bed transitional living program, and the first floor of it down here is a fitness center where clients from the residential program, the transitional program, and outpatient program are able to go and do fitness workouts 1 to 2 hours a day as directed by their case managers. So in creating this program, one of the things we realized, especially with our residential program, by putting the men's program and the women's program together, is this is very complementary for situations that come up for CWS or CPS entities when they have a parent household with both parents using substances. What usually happens? The child is detained, the child is removed from the home, and the parents are encouraged to go to treatment, usually in 2 different programs. If you're in a rural community, that could be 2 different counties. And so now you have one caseworker moving the child around to appointments, one caseworker moving the father and the mother around as well. And if it includes court appointments, it could be a full-time job, and the expenses are enormous. But more importantly, it's this disenfranchisement that happens with the family. So what we realized by building the residential program is once they agree to treatment, the mother and the child come into program, the dad goes next door in his residential program, and then the case managers coordinate their time together. The child is not removed from the family, and we have seen phenomenal results from that happening, and that was something that we didn't even plan for when we developed this concept. Another thing I'd like to say too is in putting this together, the partners that we had to bring together to make this happen were pretty wide and varied, from planning commissions, contractors. This particular project here typically would be in the works for anywhere from 4 to 5 years in planning process. It took 10 months to get through entitlement. That was all permits, all use permits, and it was a lot of community support. So when I stand up here as a representative of Community Recovery Resources, I want you to know that it is only through the collaboration of the community that we work with that we are actually able to create this. Through our county partners, our state partners, our federal partners, and on up and down the chain. It was through our conversations and understanding that this had to happen that made this occur. These are a lot of the services that take place. I'm not going to read off every one of them. I think you have them in your materials. But these are just a complement of the services that are provided to families and individuals as a result of having it all in one place. They don't have to go to another provider unless they choose to. They can get all of this care in one spot. The biggest part of well, I'll tell you, the application to USDA Rural Development, it'll give you an inkling of how comprehensive this was. 29 pounds. The reason why I know is our architect shipped it off by FedEx to Washington, D.C. 17 pounds environmental and 12 pounds of administrative, mostly financial, to get this project approved. I appreciate the chuckle. It didn't feel that way when we were putting it together. I think back on what one of the loan officers said to us at Rural Community Assistance Corporation. I don't know if any of you folks know any of them that work in there, but one of the loan officers, Robert Longman, I remember he said to me early on, back around 2008, 2009, when we explained to him this program that we wanted to create in greater detail than we're explaining it to you here today. And his response to me was, "Why do you want to do this to yourself?" And my response to him was very simple. I cannot idly sit around in my career and watch people continue to die and watch people continue to be disenfranchised and watch our communities continue to be denigrated when there's an opportunity like this to do something different. If it fails, it fails, but at least we do something different. Thank you. And by clapping, you now have just enrolled yourselves as campus change agents and will create these out in your communities across California and the country. Thank you very much. But the reality of how do we create the physical sustainability? Because, you know, the challenges for not only the entities and departments that you work in, but for the community-based organizations is how do you keep the lights on? You know, because you have to keep the lights on because the people aren't going to stop coming. And so we had to develop a process of physical sustainability that met a lot of tests. And we were able to do that. It's not rocket science. I'm willing to share it with anybody that has the time to listen. And what we ended up with was this, CBOs focus on an equal amount of public, private, commercial, and fund development opportunities that they can keep their programs afloat. They can provide an integrated staff to do this work, and it can become viable for the communities that it's in. A really important component of this is not only what we do, what these campuses do for the individuals they work with, but also the component of economic development. Nobody, and this is one of the things that our federal partners really took a close look at, especially USDA Rural Development, because if you take a look at their mission, it is about sustaining communities, rural communities with economic development opportunities. And what we proved to them was that by them lending us the money, 17.5 million of this was earmarked for construction. And for those of you that are old economists, you realize that a dollar earned in a community is going to cycle a minimum of 4 times, and there's conversations that it's more than that, but at least 4 times we all agree on. And so that created a $30 million stimulus for our community in just 1 year. It employed over 400 individuals and 29 subcontractors in 1 year. Then it added 50 positions. It created 50 new positions. Now, we had a few of those positions that transitioned from our old organization, but where our old site was and where the old organization was housed, we had 5,000 square feet. And we moved into a 37,000 square foot facility. And it created 50 positions. And if you extrapolate that out at a median wage, that ends up being a $2.5 million perpetual economic component into our communities every year. Recovery programs are viable. We provide economic development. And this was something that I think they're still scratching their head about back in Washington, D.C. They had never thought of it in that way. So those of you that have, and I'm sure you all do, have substance abuse partners in your communities that employ a lot of employees, they're providing economic development the same as any of the other businesses in the community. Uh-oh. My slides got, oh, there we go. Took a minute to catch up with it. So I talked about some of the essential partners. This next slide is about access. At least I think it is. There it goes, caught up. The access to care, which was one of the primary motivators for this project, we usually have, on a daily basis, have over 700 people enrolled in our programs at the campus. And that was over about a 40% increase from what we had experienced where we moved from. And fortunately, over 2,000 individuals just last year completed our programs. We started seeing results by this continuity of care that we had wanted for many years, which is exactly why, if you remember when I started my discussion, we were really felt terrible about the success rates that we were getting. How do we get them up? We can talk about tracking outcomes and using evidence-based practices until we're blue in the face, but until you actually start doing the work in the trenches and driving those outcomes and making the programs more successful, it doesn't happen. This next slide is the one, if I can get it to come up. This is the one that's the most special to me. The 59 children that were returned to their families last year through our perinatal program and our Hope House residential program. Thank you. Thank you. But I guarantee you this is just the start. And the cost savings alone, and you know, it's extrapolated out, and you folks that work in this know that, you know, $2.2 million is just scratching the surface with what we can do by unifying families and doing whatever it takes to unifying those family units to be self-sustaining. Some of these economic impacts I already talked about, the short term, the midterm, but then the long term, which is really the most important part, is thousands of individuals returning to contributive citizenship and less burden on taxpayers. Example, one-year outcomes. You know, I'm not going to read each one of these, but what I will tell you about this is, you know, it's a time for change in how we quantify outcomes in the substance of... Oh, it didn't go. There we go. Thanks, Tom. It's time that we learn or figure out how to quantify outcomes in a way that is more meaningful to our programs. Successful outcomes is always important. Are people completing your programs? How long are they staying abstinent? What's their quality of life? And how do we measure that quality of life in all of the areas of their life? How do we quantify a day of remission with somebody that has the disease of chemical dependency? All other diseases use a system of measuring remission, and we have yet to get there. So hopefully folks like our friends from UCLA will help us figure out those systems in the not too distant future, and we are open to partnering with you in any way we possibly can to fix our antiquated outcome systems so that they're more meaningful for us. So ideas from the campus. Accessibility, integrated and effective services properly bundled. The three major components, medical, behavioral, and social services, are extremely important in working together. Changing our delivery system. You know, just a side note about, I forgot to mention with the child development program that we created. We didn't want to take the place of child care programs. Every community has lots of child care programs. If we were going to do something meaningful for the parents that are going to bring their children to our program, we needed to provide child development specialists who were educated in being able to assess for early onset developmental disabilities, fetal alcohol syndrome, fetal drug syndrome, and their effects, so that we can start our prevention work early rather than later when they're in the schools and they're being drugged through an education system that doesn't complement their learning capacity. And that has been a big component of putting together this campus program. So, you know, we all talking about the necessity for integration of programs and services and disciplines. Any of you sitting out there listening know integration spells 2 words: hard work. Very hard work, maybe 3 words. But getting SUD, MH, and PC and support staff to mutually respect one another and work together for the benefit of the client is a challenge on our best days and a nightmare on our worst days. So I'm going to close real quickly. I want to thank Tom for inviting me. I see I have one last slide. Okay, one last slide. Before I close, I'll talk about some of the work that we've been able to do thus far. Through developing relationships with ONDCP, USDA, and individuals in HRSA. Some of you may be aware of Vice President Biden allocating $100 million to mental health services last November, a new and additional allocation. That was very important. But the most important aspect of that, those of you that are aware of it, was $50 million of that was allocated to USDA rural development. 5 more campuses. And we were very fortunate on that day that he made that announcement to receive an email from ONDCP thanking us for being trailblazers. Now we have the Federally Qualified Behavioral Health Center, our Excellence in Mental Health Act upon us, which was passed in April. And so the opportunities to create these types of facilities in your communities is more at hand than it has ever been before. As I want to close, and I want to say, any of you who want to contact me, please feel free to do that. I am more than willing to consult and help any entity that is looking to do this. And it's not really hard. It does take time, and it does take some tenacity, but I think you all have that right here. You wouldn't be sitting here today. And then this last picture is really denotes how you bring federal partners. There's a congressman in there, there's a mayor, a supervisor, some local contractors, and folks from USDA, all in that picture, and that's the groundbreaking right in front of the residential program I showed you earlier. And that's a comment from one of our clients in 2012, and that's our reception area in Grass Valley. Hope you can all come up and see it someday. Thank you.
We're gonna go ahead and have both presentations, and then we'll have some time for questions and answers. So if you have questions, you might want to, write them down, and then we'll have an opportunity for that at the end. So we'll have Wayne now.
Oops. Okay. There you go. All right. Good morning, everyone. Thank you very much, Warren, for a very inspirational presentation. And that's what it's all about. That's why we're in this field. I wanted to share my remarks with you this morning from a large county perspective, that's largely urban, but also I think something that a little spin that's a little different and hopefully be informative and useful for you is we're embedded in a public health department, so that brings a whole different kind of spin to this thing. So you'll see as I go along here. First of all, the first part of this is going to be looking at what are some challenges and recommended solutions at the state and county level that we might be able to take. So I'm kind of preaching to the choir on this part, so bear with me, but I think I wanted to make sure that we captured some of these points. So as you know, we're at a very pivotal time in substance use disorder services in California. Since the ACA and Parity Acts have been passed, we're going from a situation where there was very little funding, limited funding, and relied primarily on self-referrals by people with pretty high severity. But it also at the same time allowed counties to have quite a bit of discretion in how to allocate those resources, despite their limited amounts. And now we're moving to, especially with the approval of the state plan amendment for the drug Medi-Cal expansion, to pretty much an unlimited Medicaid entitlement, but with very specific restrictions, regulations around medical necessity. In terms of our field, we're going through a major transition. In the 25 years that I've been working for the county, I've seen us go from what was largely a self-help recovery model to what we're in now, which is a much more medicalized approach, and to, as was addressed yesterday in the health plan panels, moving into behavioral health managed care model. Some of the challenges for a county like us in building a continuum of substance use disorder services are some of these things: learning to coordinate with physical and mental health care systems, dealing with the current limitations, at least, of the drug Medi-Cal benefits, and also in terms of our residential services, the institutions for mental disorders exclusion limitation on 16 beds or less. And looking at, as we expand drug Medi-Cal as the major funding source for substance use disorder services, how do we repurpose the federal block grant, the Substance Abuse Prevention Treatment Block Grant, to complement those services under drug Medi-Cal? And for those people who are duly eligible for Medicare and Medi-Cal, how do we coordinate the Medicare substance use disorder services, limited those may be, they still add another dimension. And particularly for my interest, because I started in the drug prevention field, is what is the new role of prevention in terms of not only individual approaches, but population approaches? And I'll get into that a little bit more in a minute. Some of the challenges that continue to be one of the major challenges is access to services, both in terms of the physical capacity, expanding the number and types of services, and the availability of those in terms of the hours of operations, and also in terms of workforce capacity and the capabilities. Particularly as we're seeing with the health plans, as they're implementing their annual health risk assessments that include alcohol and drug screening, they're going to be identifying people. Once they identify them, they got to do something with them, which is going to be referring them to us. And the diversity, not only in terms of cultural and linguistic diversity, but the co-occurring physical mental health conditions, and also the range of severity of the SUD conditions is going to greatly increase. I think some of the state solutions that I'm proposing anyway, I think there's some great opportunities in the Medicaid waivers that are coming forward. We heard from DHCS on the first day about the waivers that are underway, the drug Medi-Cal waiver and the larger bridge to reform waiver. I think there's opportunities here for us to look at new payment approaches that support our more of a chronic care approach rather than the episodic type of system that exists today. Expanded access to more of a much wider continuum of reimbursable SUD services. Hopefully that will include case management and residential services as well as housing alternatives. And critical to this is more local control at the county level for the drug Medi-Cal service network so that we can integrate that into the larger SUD continuum. I have lots of suggestions for the state here. Some of the administrative actions that can be done without the waiver, I think, are reforming the drug Medi-Cal provider certification requirements, adopting the rehab option to allow a broader range of services, particularly in terms of case management and ancillary services, similar to what the mental health system had accomplished previously. Strengthening clinical requirements with specific guidelines for determining levels of care we're talking at a statewide level. And again, getting away from so much the drug Medi-Cal certification that is so clinically based right now, but looking at where we can go to deliver the services where the people who need the services are. And expanding the pharmacy formulary so that we can include all the FDA approved medications, including extended release naltrexone and buprenorphine. In terms of strengthening state policies and systems, I think to advance integrated and coordinated care, the reconsideration of adopting a dual mental health and SUD program certification and licensing, allowing multiple same-day Medi-Cal services, as Warren already mentioned, strengthening the CalOMS system, and integrating that into the statewide healthcare electronic healthcare system, so that we can start looking at comparisons with and how we impact physical and mental health as well as substance use, and adopting statewide clinical standards. At the county level, there's a number of things that we can do in terms of administrative actions right now. First of all is adopting a full continuum of drug Medi-Cal benefits in terms of all of those services that are available now. Looking at creating a single benefit package for substance use, and this is what we're working on in LA County, that will integrate both the drug Medi-Cal and all the other funding sources into a single benefit. I'm really excited about working on that over this coming year. And integrating our SUD health record into the larger county system. Much easier said than done. One of the things I think, and Steve Blake from HealthNet was talking about this on the Southern California Health Plan panel yesterday, is that the CalMedi Connect project in LA County is one of the 8 counties, of course, that are involved with this across the state. Gives us potentially a really good blueprint for this coordinated care approach. And some of the principles that we've striven to use are that there is no wrong door approach to accessing any kinds of healthcare services, including both physical and behavioral health, establishing a single electronic health record for each health plan member, having a single case manager for each health plan member rather than separate case managers in each system. And then, at least for the health plan side of this, the capitated rate with outcome and performance incentives for all the partners, including mental health and substance use. So we're really using this both in the mental health and physical health and substance use systems as a way for us. It's really brought us together to look at how do we work together with the same people. The other thing that I'm really excited about is the LA County Health Neighborhood Initiative. You heard from Dr. Southard describing this for today, or this session, as well as in previous policy forums. But I think from the public health and substance use side, there's another perspective on this, and we're really looking at this as Dr. Southard has emphasized, as an approach that's centered around people in the community and bringing together physical health and mental health and substance use and other community supports to really address what are those unique needs in that community or neighborhood. There are two major components on this. First is developing regional service delivery networks, and the other part of this is establishing population-focused efforts to address local health disparities. So one of the most unique things in this is that public health is coming into this. And public health brings in some unique assets in terms of the public health surveillance data that we can use for planning. Also brings in all the different preventive approaches that public health has been doing, including and also the environmental health aspects of this. Also, from our side, from the substance use side, what I'm looking at right now is what can be the role of primary substance use prevention into this. And our prevention programs have worked for many years, working in communities at community level and in organizing communities to change conditions that influence alcohol and drug problems. And I think that aspect of it is really exciting to me. Another side, just emphasizing the networks. I think this part is pretty straightforward. We've already begun this in looking at regionalizing the cooperation between the physical, mental, and substance use systems. In the community level, providers have been doing this all along, but I think this is pretty revolutionary for county agencies that have been working in silos for so long. This is the part that this slide illustrates what I'm talking about in terms of addressing population-based health disparities. We see premature mortality, poverty, chronic diseases, years of productive life loss. We know that those are all influenced by behavioral health. And behind that, we're looking at what can we do, which would be making behavioral and physical health care more affordable and accessible and available, addressing the economic empowerment and the educational opportunities, changing community conditions, and changing public policy so that they're more supportive of healthy lifestyles. And working with other community supports like the faith-based organizations and other community service organizations and peer recovery support organizations. And through that all, then addressing those health disparities that we see so much. In the process of doing that, which I think the substance use prevention programs can really contribute to, is engaging those communities in helping them mobilize themselves to address these health disparities. Yesterday morning, I missed our morning session because I was meeting with some people in South LA and the Service Area Advisory Council to present this idea to them. And they were very open to the idea. I mean, it wasn't a new idea for them. They're saying, this is what they've been doing for many years. Had some skepticism about the effectiveness of the county agencies working together and being able to do that, but very supportive of us and agreed to work with us on this. So as I was saying, we're launching this. We're able to get a Blue Shield Community Foundation planning grant through LA Care, which is the county health plan, to begin doing the planning. So we'll be engaging some consultants to help us with that planning process over the coming year. We'll be bringing together those regional networks, and then most importantly, engaging community residents and other stakeholders in this process. So we're off, and look, I'll keep you posted on where we're at with this. And those of you who are from LA here, you'll be engaged in this very soon if you're not already. Okay, and I think at this point we're going to open it up for questions.
Thanks, Wayne and Warren. So we have some time for question and answer. I hope you've thought of some questions, because we would like to have some more interaction here with our presenters. And I don't know if there's a mic. Oh, Alice has a mic. Okay, good. So I'm just going to open it up for anyone that has any questions. Jennifer, you have a question, or are you just running a mic there?
I am just running a mic.
Okay, all right. So we've got two microphones. There we go. And you guys can use, you want to use this mic?
I'm wondering about efforts in all of this to partner with schools, especially in the junior high and high schools, as far as substance abuse prevention, to teach issues like personal responsibility and that type of thing early on, so that they understand very early the consequences of certain behaviors. This kind of thing never gets addressed in behavioral health until after the fact, and it seems to me that that would be an effective prevention strategy.
You want to speak to that?
I can speak to it from our perspective in developing the campus model. I think it really goes outside of the campus work that we're doing, but just being a community-based organization and being open to work with all areas of the community, especially the schools, and understanding that's where a lion's share of our prevention work comes from. In the counties we work in, we work on a number of different levels with the schools. Most recently, we worked with Placer County in securing some MHSA funding to work with the Placer County Office of Education around their PBIS program, and being a substance abuse component of that, being one of the ladders on the scaffold, so to speak, in PBIS terms. And then in another county that we work in, Nevada County, we provide a diversion program which is focused around teaching teens about making better choices in their life for those that are found to be under the influence or in possession of on campuses. And then most recently, we've been talking with some of our partners in Nevada County about actually certifying some drug medical clinics on site. This is where you'll have licensed behavioral health and certified substance abuse counselors on site too. So yeah, it needs to occur at all levels. Wayne, your system seems to be set up for that as well.
Yeah, I really support that too. And when we're talking about prevention of substance use, we're not just talking about prevention of alcohol and drug problems, but we're talking about prevention of all kinds of things. Because the protective and resiliency and risk factors for substance use apply to across the board. So in terms of addressing community-based health disparities, we have to include the schools as key partners in that.
It's Marv over here. Marv Southard from LA County. I wanted to thank Wayne for his presentation, and also to say that we have long been in LA mental health good, strong partners with LA public health substance abuse programs, but through the development of these health neighborhood program, I was ashamed to discover how much I did not know about what the public health community efforts that were going on. And so, as Wayne indicated, we tried to link up the regional public health officers and our regional district chiefs who run our programs in our geographic areas to have them plan together, which remarkably enough we had not done before. So it's already paid benefits in that regard. But my question was going to be both in terms of the kind of planning we're doing. It seems like the diversion efforts that we've done in the past need to be brought to a new level in a kind of integrated fashion, both because of AB 109, but also because of other kinds of population pressures in our local jails. So I'm wondering if you could comment further on how prevention of recidivism and reduction in jail populations might be addressed by the innovative things that you're planning.
Wow. In terms of the health neighborhoods, I think that what we've seen is that people who are returning to the communities are returning, I guess the largest proportions of people who are returning to the community are returning to the communities with the most daunting health disparities, the poorest communities of our county. And so this is going to be key, as I see it, to by improving the community conditions, to be supportive of people reintegrating into the community, and being successful at that, and not returning to the juvenile or the criminal justice system. Is that kind of like Dr. Souther, what you're? That's kind of the area that you're considering?
Yes.
Okay.
Do you want to say anything, Warren?
I had no, I mean, as far as your neighborhoods, yeah, it doesn't really fit into the campus model.
Okay.
Yeah.
Is there another hand over here?
Yes.
Oh, yes, please.
Thank you for your inspiring talks. I think we're all impressed by your outcome measures and how much success you've had in Nevada City. And I was wondering if you could reflect on that. Is that from the integration or follow-up treatment, aftercare? What would you think is causing your great success?
And Warren, can I add to that question? Because that was similar to one I had. So we know that we have good outcomes, for our treatment and prevention services, but both of you indicated that there are some gaps, or that our current system for measuring outcomes needs to be improved. So I'm kind of adding on to her question, about how you achieve those outcomes, but then how can our measurement system be better improved to show those outcomes?
Thanks for the question. From my perspective, I think the way it gets improved is you have to continue drilling down. You have to continue quantifying the outcomes, taking a look at what they actually mean. And so that means the community-based organization, in partnership with whatever partners it has to invest the labor to actually create the outcome system. And then what does it mean in terms of measurement, and how does it integrate with other areas of healthcare? Just quantifying whether a person successfully completes our program or not, certainly that gives the public some semblance of assurance that their dollars were well spent, but what does it mean to the community? What does it mean to that person's family? What does it mean to the comorbidity of that individual? How do we quantify the years of life that we've saved? And I don't think that we've scratched the surface in how to do that yet. I don't think I answered your question either.
Yeah, I'm sorry, because I jumped on that question. Go ahead, though. Whoever asked that question, did we answer it sufficiently, or it seems like you had?
Well, I think she was asking, how do we do it?
How do you do it?
Yeah, I mean, you just have to invest the time to continue taking a look at what your programs produce. And I think that that's one of the challenges that community-based organizations have, because there's no billability for that. You have to make the internal investment in making that happen.
Did you want to say anything, Wayne?
I hope I'm not getting too technical here when I'm in my remark here, but I'm looking at, I think in LA what we're looking at is, and other counties may have already done this, is looking at, up to now, the California outcomes measurement system that the state uses for compiling information about substance use services is largely based on the federal minimum data set requirements. And what we're looking at now with the expansion of Drug Medi-Cal is what can we use in terms of the bringing in the Drug Medi-Cal billing system and applying that kind of data to supplement the demographic self-report kind of data that the CalOMS compiles. And so that we can start looking at outcomes. And of course, UCLA ISAP has been a partner with us over this for many years. And that's what we're looking at in terms of being able to start compiling data that we can use to assess outcomes and demonstrate those outcomes.
Okay, Jerry, did you have a mic?
Yeah, Tom, thanks. Yeah, I have a mic. I'm Jerry Wengert from Riverside County, and I think this is primarily for Tom, just a general question. We in Riverside have sort of the semblance, just the beginning of a little work group between public health, mental health, drug, alcohol is one agent, one department, and our transportation folks. And we're looking at data around DUI, which seems to have spurted upward in the last couple years, just tremendously upsurged. So we're starting to think about what else can we do around prevention. And so we're heading off in different directions, looking at supply and neighborhood markets, things like that. However, and the board's really interested in this, so it's got high visibility if we come up with anything that's useful. So I'm asking Tom, have you in your public health approach and looking at data, do you do anything around DUI? Have you had any history?
You're not, it's not for
I'm
me,
sorry,
right?
not
You're
Tom,
probably
Wayne,
Okay.
Wayne, I said
I'm
it
starting
wrong.
to sweat bullets here.
Okay, Tom, I'll put you on the spot. And then after you're done with that, no, I'm sorry. I'm sorry. I was looking at Wayne saying Tom.
Okay, yes, that's really a concern of ours as well, in terms of, because we know the strong link between problems and access and availability, particularly around alcohol. And so our prevention programs are looking at that, and what they're trying to do are looking at problem outlets, using GIS kind of data to map out where those problems are. I would suggest, Freed Whitman up in Berkeley could really provide some real help in that. He's been a great resource for us on that too, in using mapping data to identify problem areas that we can focus our interventions on.
So just to follow up, there's a lot of published research. We've kind of dug in and seen a lot. There's quite a bit in LA and even in Riverside at UCR.
Yes.
Have you headed in any particular direction? There's been a lot of billboards about DUI. Well, that doesn't do it. So we've got to figure out some different ways to approach it in prevention. Are you heading in any certain direction?
In terms of DUI services
Yeah,
themselves?
in terms of the prevention aspect of DUI, the public education. I don't know what I'm talking about yet, because we're just starting, we're just starting.
I think something that we're just beginning to scratch the surface on is the value of partnering with primary care around screening and brief intervention. And now that the health plans, our county health plans have embarked in a major training of their primary care providers on SBIRT. And so now what we need to do is link with them so that they can do a better job of intervening with those folks early on as soon as they're identified.
Thank you.
Can I add to that?
Yeah, sure.
Along with what we do in a rural community, and I think you mentioned that you already have a task force pulled together, and if that includes some of your folks from the DA's office, law enforcement, possibly applying for some funding through Office of Traffic Safety to do a pilot project that you might develop, developing DUI programs, DUI drug court programs in the judiciary, as well as social host ordinances, having sweeps for sales to minors as well as being able to fund law enforcement having more traffic stops, DUI checkpoints in your communities. And And then one other point in talking with your judiciary around multiple offenders is requiring them to have an enhanced program more than just what the 18-month DUI program requires, actual outpatient programming in conjunction with that. Could be a number of other steps that you could take as well.
We've talked to a number of legislators over the years about, because every year you see new bills being introduced to increase the length of time for DUI programs, or, people have to be in these services. But there are a couple of states, including Oregon, that have their DUI is assessment-based. So everybody that, your first time you get a DUI, person has to go for a full substance abuse assessment, and then if as a result of that assessment, if they're seen as having significant problems with alcohol or drugs, then they're put into a program, more than just a DUI. I mean, it's an actual treatment program, and so that's an assessment base, and it seems to be working well or better than our system here. So that's something that we're looking at. It's just would have to be done through statute, and that's always a challenge. Yeah, Tom?
I had a question for Wayne on the public health side. I know there's folks on the public health side who do, you have the prevention folks that do a lot of health education and how that's utilized for drug and alcohol abuse prevention. And also, there's also statisticians usually in public health departments that oftentimes provide really very relevant information. If you could address that for us.
Yes, thanks, Tom. Yes, that's what I'm seeing as what public health will bring to the table in our efforts are what I was alluding to as the public health surveillance efforts. So we have tons of epidemiologists that are monitoring all kinds of health conditions, and we produce. If you go on to our public health department website, you'll see a LA Health survey that we do biannually of community residents, and also analysis of those statistical indicators into by our service planning areas. That's how we divide up the county, looking at the various indicators, and including mortality and morbidity statistics and all that stuff, which I'm not a master's in public health, so I don't know all the technicalities of that, but I do know that those are very helpful. And for example, our prevention programs are already using those data for helping our planning purposes. And so I think that part of it, also in terms of the environmental health aspects of it, and looking at, from building inspections and all those kind of things, looking at the built environment and how that contributes to health conditions, health disparities.
I had one other follow-up question. It's a little bit different subject, and that is adolescent treatment programs. And that's for Warren and Wayne both in your programs.
Yeah, I think that's an area that we have been really remiss in addressing. That's something that in our we're just embarking on a whole major stakeholder engagement process to part of the transforming of our SUD system, and that's one of the major areas that we're focusing on, is how can we build up our adolescent treatment capacity.
And interesting enough, from a large county to a small county, and we're having the same challenges in developing those processes and funding resources to really focus on that population. What we are experiencing, though, as a community-based organization, is many more partners are willing to come to the table now to discuss it. Even though, it's prevalent, it's in our community-based programs. I'm sure it's permeated throughout other departments and counties across the state of California, and there really needs to be a stronger initiative towards adolescent services. But, integration's an action word. So.
Yeah.
I think that what the greatest opportunity is now with expansion of health coverage, and substance use being one of the essential health benefits, that all families now have access to those services. Now we have to build those services so they can have access to those.
Along with that, I just wanted to add a comment that, and I may not know about this, but in my understanding around the expansion of the benefits and a child being covered up until they're 26 years old, when it comes to the Medi-Cal, adolescents are carved out. And that creates a whole different world. It creates funding expectations on counties that's different than treating adults. And so there needs to be work there. There needs to be work done at the state level. And then if you have a family that qualifies for, say, just Medi-Cal benefits itself, when it comes to substance abuse, it's a different story. Drug Medi-Cal is a carve-out. And I think you offered up some great examples of how to create a benefit program that you could serve adolescents under, because that was one of the first things we heard from a number of our county partners, that, okay, well, now the expanded benefits, and now we're going to start serving the adolescents. Well, and if you tell me how to do it and not make them a carve-out, as regulation requires, then we're, as a community-based organization, we're more than willing to do that. So we need to work through that yet to make that happen. And if we're able to do that, maybe the state can help us, maybe they can make that part of the waiver or something like that, then we can get those services to adolescents much more easily.
Good. Okay, I'm getting the the signal here that we're about out of time. So is that like stop now, or do we have time for one more question? Or Alice, we have time for maybe one more. Are there any more questions over here?
We need to pay attention to homeless youth, and I'm glad that Tom mentioned it, the carve out of youth, that, there's a significant number of homeless youth that are in need of services and they don't have coverage.
Yeah, it's probably the biggest unmet need that we have right now in our system. Okay, any closing comments, or is that it? Well, let's thank our presenters again for this.